Yeah, so thanks for coming, first of all. So we're just going to talk about our project that we did as part of our course to become physician associates. And we created it in order for homeless people to have more opportunity to make their end-of-life choices known. And I'm just going to talk a little bit about why we thought that was important, or why I thought that was important, really, because I started the project. And then I'm going to hand over to Alice to talk about how it was implemented, and she did an audit on it and had a look at whether it actually made a difference or not. So why did it come about? We kind of had to do a health improvement project for our course, and there was an opportunity to do an audit or have a look at something that was already happening and make a recommendation. I started the course in 2017 and then Alice in 2018. I've got a bit of an interest in health inclusion and a huge interest in end-of-life care and having greater choice at the end of life and how choice at the end of life impacts on death and how good a death can be. And then Alice had got an interest in health inequality when she was working as a nurse in oncology and haematology. So that's why we were both kind of interested in this area. We had a huge chunk of time to work on a health improvement project, really, and it was quite a luxury looking back. And a lot of people thought, I've got loads of time, I need to churn out a project, get my mark, and then crack on with this hideous course that we'd undertaken. But I wanted to do something useful, so I decided to try and make an improvement that actually might make a difference in an area that I was really interested in. And then Alice took over the baton when I had to focus on my exams and then on getting a job, basically. So it had to start with a belief from me that more choice and control at the end of life makes for a better death for everybody, not just for the patient, but those around them, including their loved ones and the people who are administering their care. And as we have heard a lot over the last couple of days, end of life has become a priority, but the quality of care can be influenced by age, gender, identity, sexual orientation, disability, diagnosis and social situation, and often the people who need it most get the worst provision of care. We know that homeless people are at risk of premature mortality and are more likely to suffer from the trimorbidities that we've heard about already. In Norwich and East Anglia, much like the UK as a whole, there's a huge increase in homelessness and rough sleeping, and it's not showing any signs of slowing down. So these were all in my mind when I was thinking about what project I could do. We're really fortunate in Norwich to have City Reach, which is a homeless specialist healthcare provider, and they've got about 700 patients, 450 of which are homeless. And one of the things that I found really interesting when I was looking into this was that actually homeless people tend to have a greater desire to write down their choices at the end of life for their end of lives than the general population. And actually the general population have got quite an interest in it. So that I found really interesting and thought that's kind of a scope for my health improvement. And then most people agree that making advanced statements improve the chance of you having a better end of life experience. And it's particularly important with an increased risk of death. Early death, because we've all got a risk of death, and those with more nomadic lives, it's kind of important for them to make their wishes known in a way that they can take with them. So that led me to the idea of an end-of-life choices form specifically for homeless people that was focused on that group. So I was conscious not to just go, I know what I think and let's impose this on everybody else. And I had some stereotypes that I wasn't aware of when I first started working on it. So I asked lots of people for their input before I kind of cracked on with the form. I did a survey of hostel managers, GPs, nurses, care workers, and also spoke to the patient participation group and had a focus group with them to see if there was a need for this improvement that I wanted to make, and to have a look at what that improvement might look like. And I found, none of this was particularly surprising. I found that most people I asked felt that homeless people don't die well or occasionally die well, and everybody felt there was room for improvement. I found that most people felt that choices about end-of-life care were limited for homeless people, and everybody was in favour of more choice. And everybody that I spoke to supported the idea of a form to kind of consolidate all these thoughts. If it had been an easy fix, it would have been done before, apparently. So I knew it wouldn't be easy, and I knew that there were going to be barriers kind of from the start. So I looked at them from the start because I wanted to try and make an actual change. So barriers that we identified early on were access and time to support people to fill in these choices. I identified that this isn't an easy conversation for the person instigating the conversation or for the person having the conversation. And that access to healthcare goes both ways. Some people don't want to be accessed. So there was also that to kind of consider and try and overcome. There are lots of really good tools for making end-of-life choices known. I used to work for Compassion in Dying, who provide advanced decisions to refuse treatment. So I knew that there were lots of tools available, and I didn't want to reinvent any wheels. So I basically stole the best bits from what already existed. So I looked at what Compassion in Dying had got. There's 6 steps paperwork that somebody might be familiar with, which is really good and is used in care homes and residential areas to approach the end-of-life questions in 6 steps. I thought about what the patient participation group had said and then came up with a kind of my first thought form and discussed it, piloted it, and then made some changes and then piloted it again. And one of the things that came out of the conversations that was quite interesting was that my focus was on end of life. I want people to die well, but actually the form had a much broader effect that if people who weren't facing the end of life had to think about the questions that were on the form, it could actually inform their choices going forward and may have a positive impact on people's lives as well as their deaths, which was a nice kind of added extra. So this is what the form looked like. I'm not going to go through all of the different things, but the things that kind of surprised me in retrospect was that the form doesn't start with what is my name. The form starts with what I like to be called, and that was something that came from talking to people with lived experience, that actually sometimes the thing that they're called isn't what the name they were given when they were born, and they don't want it to be. Next of kin was another really important one that came out early on. The patient participation group didn't want that to be the thing on the form. They wanted the person that they wanted to be informed about what happened, and actually that's kind of nice to apply in broader practice as well, that next of kin doesn't necessarily mean the person that you want to know about things. And then the things I want to do before I die is one of the things that came up from talking to people, that actually having that conversation, having that thought as you go through a process can make you think, actually, I'd like to do this before I die. And at the moment, my situation means I can't do that. What can I do to change that situation? So it's not just about the kind of end bit of life, but actually about the broader living. And obviously, forms are quite impractical. Nobody keeps their bits of paper. So we've got the paper form that people can have a copy of and can keep with them. And it's quite helpful in emergency situations to have that form. But it's also been uploaded to System 1, which is the software that is used in the Norfolk area. So it can be filled in piecemeal. So the clinician can have a conversation about one of the things in the form and then come back to it another time. So, and then it's always on the record and can be changed as required. So here's a few of the kind of pilot responses, and I think this is quite nice in highlighting the kind of things that people said, because the form is a bit boring, but actually the things that people write on the form, that's what makes it interesting, people's choices. So that's that, and then I'll just show you a few more and let you have a read. And the responses were completely different depending on the person. I mixed them up a bit because the patients were happy for their responses to be used, but I just mixed them up so that they weren't completely verbatim. So then I did this bit and then kind of wrote up my project, got my mark and kind of forgot about it a little bit. And then Alice was a year behind me in her training, and she had to do a health improvement project as well. And fortunately for all of us, she decided to pick up the baton and carry on and do an audit and actually push the project forward. So I shall hand over to Alice to tell you about what happened next.
Thank you, Jo. So I guess I wanted to come back in and see how we were doing with it. Jo had implemented it and started that conversation. However, when I came back 6 months later, actually I found that only one additional form had been completed. And I really wanted to know why that was. I'm just going to move over a little bit so I can hear. So I did this in 2 parts. Started with a project review using an NHS improvement tool. I asked the staff to complete an anonymised survey just to establish any learning from the project thus far, if there'd been any benefits or barriers to implementation. And then I wanted to look closely at the patients who would be using the form. and also support the practice to complete them if I could. The patients we were considering for my choices, I just wanted to go through, were those who we wouldn't be surprised if this person would die in the next 6 to 12 months. And that surprise question we use in healthcare quite often determines whether patients should be managed on the gold standards framework. So that's where patients identified as palliative have their needs discussed, and we regularly consider them. So at CityReach, we describe these patients as having advanced ill health, which I think is a term that has been very much informed by the work that Dr. Schulman's done. And these patients aren't just those that suffer from long-term conditions such as cancer, but also on this list that we consider are also patients who might have had a recent overdose and admission to hospital, and are engaging in quite risky behaviours. So we invited them to complete the advanced statement, my choices, and as Jo said, we uploaded it to their medical records. So the project review, the response rate to the survey was 71%, which is really good. The staff responded to us, and you can see this in this tag cloud, what they sort of, their own words, how they describe it. They were really supportive of the initiative, and I'll just use a few quotes from what they've said to us. So they said that the form facilitates difficult decisions about a person's journey or state of health, and it really encouraged reflective practice by allowing patients an opportunity to reflect on their priorities and help health practitioners to document these. However, they also recognised, as Jo found, that there were real barriers encountered, primarily lack of time and lack of resources. They understandably highlighted that in order to complete these forms sensitively and ensure that all concerns raised by the patients were dealt with appropriately, that they needed the time to do so. So they said the patients need time and space to think about their wishes. At CityReach, a standard clinical appointment is 15 minutes, and we took this to management, and they agreed that if we were booking my choices appointments, we could book them as 30 minutes, which was really good. They also said that perhaps staff felt we should move this conversation away from a clinic room, so it occurs in a less medicalised environment. So actually, a lot of the conversations would take place in sort of a waiting room with more comfortable chairs and a lot of natural light. So in terms of my choices itself, by the completion of the audit, which took place, I first started in January and finished in August, and I spent a day a week there. As Jo said, we had quite an extended amount of time, which was great. So there were 52 individuals considered for the intervention at the end. The median age was 42, and this was from an age range of 24 to 64. 77% were male of those individuals. Almost 2/3 suffered from trimorbidity. So they had their physical health condition, mental health distress, and or substance misuse. We know that homelessness has profound implications for health, and it's really well evidenced that that the health of the homeless population is worse than that of the general population, and our clinicians acknowledge that the people we were discussing here were really complex, with complex health and social needs. Indeed, many of them were young men and women who really hadn't considered their end-of-life care needs before this. I think a really important point to make is the fact that most of the forms that we completed were opportunistic. So we found that planned appointments really just weren't as effective. And actually engaging people, although all of CityReach's appointments are booked appointments, often people would just come in and walk in and ask to see a clinician. And if we were there at the time and we could capture them and they were happy to have this conversation, that's when we got sort of the biggest benefits out of being able to complete the forms. There was quite a high rate of non-attendance for scheduled appointments, and some were cancelled as well. But as you can see on the right column, opportunistic is definitely how we sort of managed to have those conversations the most. Who completed them? They were completed by clinical staff, and that was a decision we made at the practice, that it would only be clinical staff doing this. And generally, GPs, nurse practitioners, previously the practice manager had completed one in the past, but the majority of them were completed by myself as the PA student at the time, and I think that was, so much of that came down to the fact that I was an additional resource to the practice and therefore could complete them opportunistically. So it resulted in that higher completion rate. I was also able to travel to hostels and provide outreach, which was not possible for many of the staff. And as a result of that, sort of engaging with hostel key workers and asking for their feedback and how we could share best practice, resulted in a change to the form so that we could share it with the hostel key workers should the patient wish, hopefully leading to more coordinated care. So, as you can see from the table, the bars are the registered patients identified as having advanced ill health. So this is the patients on the GSF list, starting in January and moving upwards to August. There were more patients added, and it could be quite speculative observation, but that perhaps the increase in discussion meant that we were more actively considering patients of concern, because we were talking more about their needs and their end-of-life needs. Perhaps we were placing more patients onto the list as we went through. Research indicates that most of the healthcare that homeless persons access in the last year of their life is often from secondary care services rather from the GP or community hospice. So it's really hoped that by actively considering the end-of-life care needs of those with advanced ill health at City Reach, we could seek to improve the care that these persons receive. The report by the CQC said that in order to improve the continuity of care, the homeless healthcare person's records should be on available to hostel and outreach staff, available to A&Es, available to out-of-hours emergency services. And we sort of hope that this model of my choices, the use of my choices, is a bit of a development to this model of care. So I'd just like to end really by talking about one of the patients, one of the people that we met. And I'll call him Mr. X. So he was a patient at the City Reach service. He suffered from chronic alcoholism and regularly attended hospital with alcohol-related complications. We met at City Reach. He was really engaging with alcohol services at the time and was being housed in a local hostel. On the day I met him, he was very pleased by his new clothes and recent haircut, and was more than happy to have a conversation with me about his choices and what he wanted. So he consented to complete a My Choices form. Shortly afterwards, he became very unwell and was admitted to the high dependency unit at our local hospital due to a gastrointestinal bleed. He was unable to communicate to staff, and despite his frequent attendances to the hospital, he hadn't consented at the time to give any records of who he wanted contacting, and the hospital didn't know who his next of kin was. So, although it hadn't been set up in place, the hospital actually contacted City Reach just to inquire as his general practice service whether we had any more information. And his My Choices form was reviewed. On it, he'd clearly documented who he wanted contacting, he'd given their details, and had quite specific plans about who he wanted informed of his care if he became unwell. We shared this form with the hospital, and it meant that his family had the opportunity to see him before he died. Although we don't have much data from the patient's voice, I think for both of us, this was the one bit that actually made it all worthwhile for us. So, I will leave you with some feedback from the clinicians about the My Choices project. This is what was said, and just wanted to say a huge thank you to the patients who really graciously shared their experiences with us, but also the staff at City Reach for mentoring us throughout the whole thing, including Dr. Heidegger Klink, who has been very, very influential. So thank you very much.
Thank
you.
Fantastic. So we've got 10 minutes for questions. I just wanted to ask first, Joe, when you said when you went back, there was only one instance of the care plan being used before you came back, and you said it was about resource. Do you know what's happening now?
Yeah, the service service has undergone quite a lot of change recently, and we went back. I think I went back a sort of a month or two afterwards to present the data to the team at a big meeting, and they were very honest about the fact that without that sort of additional resource there, they weren't able to input it as much as they would like. And I think that feedback is really, that's written here, is the fact they haven't been able to engage it as much as they would have liked to have done.